Being the part of the DMDSC family, first of all, I welcome all the delegates who has come here to attend these sessions. Thank you everyone for attending our update. And I am going to speak on my experience and our institute's experience with the fibroscan at our diabetes center. And I thought Dr. Rajiv Chawla is little biased for me when the music started coming in from that side. I thought he wants to introduce me with the music for the lecture. Anyway, in the next few minutes, I will be talking about our DMDSC experience with the fibroscan. And I'm Dr. Brijendra Srivastava here. And this is the ADA consensus statement has recently published in the diabetes care. And they have very clearly mentioned that previously what was known as the NAFLD has become now called as a metabolic dysfunction associated steatotic liver disease. And particularly in the type 2 diabetic subjects, because we are going to show our data on the type 2 diabetes. So obesity and type 2 diabetes makes a higher risk for this, and it also affects nearly 2/3 of the patients with diabetes, much more than the NGT population or the normal glucose tolerance population, and it can lead to the cirrhosis and steatohepatitis and other hepatocellular carcinomas, overall liver related mortalities. But apart from that, it is also having the extra hepatic manifestations, and we should be taking care of this situation. And it is also a leading cause for the atherosclerotic cardiovascular disease, and I will show you in the next slides. So the thing in the type 2 diabetic individuals, once we talk about the MASLD, from straight away it can bypass the stage of cirrhosis and directly develop and progress to the hepatocellular carcinoma. And once we diagnose it early, we can definitely alter the course, and even we can, just now the previous lecture was on the remission of diabetes, we can very well bring back the steatosis and fibrosis back to the normal. This is the landmark paper by ICMR NDAB, and Dr. Anjana was the first author in that, and here we have shown that what is going to happen with the NCDs, especially in context to our country. And as AD has also endorsed that obesity and type 2 diabetes is the leading risk factor in the diabetic subjects. So if you look at this data, we can see very well that the 101.3 million, more than 100 million people have diabetes, and 136 million is having pre-diabetes. If you look at the generalized obesity as well as the abdominal obesity, we are talking about abdominal obesity in our data sets. So it is around 351 million. So with this much of the glycemic dysglycemia along with the obesity, we are going towards the epidemic where there should be a very fast progression of the MASLDs and MASH. This is a very good editorial written by Professor V.Mohan and Dr. Sheshadri in the Journal of Diabetology. So what they are talking in this paper, that it is not only the diabetes, it is not only the hypertension or dyslipidemia or MASLD, everything happening because of the change in the metabolic milieu in the body. So bidirectional associations are being seen with the dysglycemia, liver fat, obesity and hypertension, and each of the every component of the metabolic syndrome is affecting other. So we should not only treat the blood sugars. That's why I tell to my patients also, HbA1c is just a part of your body. You should not only look at this. You should look beyond this. So we have to change the metabolic milieu. All the factors are interrelated, and they change the phenotype and causes even the expression of the T cells are changed in the body. So that's why we should look into that on the overall metabolic milieu of the body. And this is the steatotic liver disease classification given by the ADA consensus statement, and we can very well see that they have classified it in the MASLD, MET-ALD, ALD and other causes of SALD. So here our area of interest is MASLD, and we can diagnose it by any incidence or evidence of steatosis, and along with that 5 cardiovascular, any of them should be there, like our BMI or the dyslipidemia, triglyceride levels, HDL levels. And if you look at the BMI, this was another paper which was published in the Diabetes, Obesity, Metabolism by Dr. Jagar and Professor V.Mohan et al. Here we can see when the BMI is more than 23 or obesity is there, fasting is more than 100, or somebody on the treatment for diabetes mellitus, BP of 130/85 or triglycerides more than 150, or there is a low HDL cholesterol either in men and women. It can, any of this along with the steatosis, we can call it as a MASLD. So this is from the same paper. I am quoting the progression of hepatic pathology, how it moves. There are susceptibilities like genetic susceptibilities there, metabolic dysfunction is there, gut microbiome also plays a role in that. Sometimes even the gut microbiome can cause the intestine more permeable and its wider effect can be felt, and immune mediated mechanism could also be there. So if you look at the healthy liver, it progresses to NAFLD and then NASH, then cirrhosis, and then ultimately hepatocellular carcinoma. So what causes all this pathophysiology? It is the hepatic triglycerides which comes, and it is the obesity, type 2 diabetes, and inactive lifestyle. So as our previous speaker was talking about the remission, so these are also things, if we take care of it, all those things can also help in the remission. Our lifestyle plays a big role, our lipid management plays a big role, our weight plays a big role in the progression. And after that, we know there will be lipotoxicity, glucotoxicity, insulin resistance itself can lead to the complications. And once the cirrhotic progression happens, means NASH is developing, we know that there will be the hepatocyte ballooning, progressive fibrosis, and then ultimately cirrhosis will develop and hepatocellular carcinoma. So what is most important thing in this slide that we can see from NASH as well as NAFLD, if we work hard, reduce our weight, control our diet, follow the instructions of the physicians, we can very well revert it back to the normal. This is the extrahepatic manifestations of MSLD. We can see that we know that hypothyroidism is also associated with the MSLD. Even it is now being treated as a different entity, that is hypothyroidism induced MSLD. And coronary heart disease, diabetes, and metabolic syndrome, chronic kidney disease, colorectal tumors. If you look at this, what you will find, thus the mortality in any patient with MSLD is not because of the liver related. It is the third cause of the liver related issues or malignancies. First cause is the cardiovascular disease. So any patient who is having MSLD is at risk for the cardiovascular disease. Then after that comes the extra hepatic cancers like colorectal cancers are very common. Now COPD is also, OSAs also associated with the MSLD. So what could be the, how we can go for it? Everybody is not having the facilities of fibroscan even in the small cities, tier 3 cities or the remote places. So we can simply use this scores, non-invasive scores to find out and detect the liver fibrosis. If you look at that, there are FIB4, we can call it as a fibrosis 4 index, APRI and NFS. So these are the formulas by which we can calculate. In a nutshell, if the FIB4 score is less than 1.3 or then it is a low risk of MASLD. If it is more than 2.67, it is high risk. So simple by calculating the platelets and taking the ALT and AST into consideration, age in years, we can calculate this. So it is very simple score, it can be calculated, and a lot of online software itself is available. You can just put the data and you will get the values. So if it is maintaining below 1.3, it is safe. One thing I would like to tell about these scores, that they are very strong in predicting the normal patients. If the values are normal, it means we are not, means chances of getting MSLD will be lower. Then there are the imaging modalities for the MSLD in type 2 diabetic subjects like abdominal ultrasonography, CT, MRI, and the vibration controlled transient elastography or fibroscan. I will be discussing about this. So the ultrasound, we know it can detect the fat, but it cannot comment much confidence on this fibrosis. And if you look at the CT, CT is also very good in picking up the fat content, but not the fibrosis content. If you look at the MRI, it is the gold standard as far as the imaging is concerned. It is very good in picking up the fibrosis as well as the steatosis. And VCT is good, not excellent, but good in picking up the both. So if you look at the role of VCT in liver disease or fibroscan, what we will see, what is fibroscan? Fibroscan is the instrument where ultrasound waves of around 50 megahertz are used, and by this we can calculate the elasticity or the stiffness of the liver. So the shear wave velocity, by the wave which is going inside the tissue or the liver, we measure the velocity of that. The faster it is moving, and that higher will be the stiffness. So how is the formula? If you multiply the 3 into the shear velocity square, we can very well get the stiffness, and we measure it in the kilopascals. And the cap is another thing, like it is measuring the statosis with the fibroscan, and it is mentioned in the decibel per meter. We can also measure cap by this, and by deciding the grades as well as the grades of cap and KPA or this fibrosis, we can quantify the risk in the MSLD patients. It is very simple. We can see that there is a fibroscan here, and we can very well see the probe, and this is the patient is lying down, and any trained operator can do it. It just takes 5 minutes. So if you look at the image wise and see how we will diagnose the advanced fibrosis. If you look at the fibrosis stage, as per the KPA, if it is less than 6, is very much normal. And if it is more than 8.2, then only we call it as a significant fibrosis. So more than 8.2 and more than 9.7, so this is the fibrosis 2 and fibrosis 3 stage. This is known as the significant fibrosis stage. If you see someone in the significant fibrosis stage, you can think that there will be more fibrotic changes in the perisinusoidal area, and bridging fibrosis could be there from central to portal or central to central. So this fibrosis can ultimately lead to the cirrhosis or the advanced stage. And this is the classification we have shown. Less than 6 is a normal. Even less than 8.2 is also not showing any significant fibrosis. More than 8.2 will be showing a significant fibrosis. So what is CAP? CAP is the controlled attenuation parameter, and what is measures, it is just the how the attenuation of rate of the ultrasound wave we are measuring. If the attenuation rate is low, the CAP will be low. So it ranges from less than 238 to the 400. Higher is the CAP, the more is the amount of statosis. So what is the clinical evidence with the fibroscan in type 2 diabetic subjects? This is the two-center study, and it has been published here. I was also one of the author in this, and where we have mentioned the prevalence of hepatic statosis in the Asian individual with type 2 diabetes. So this is only not a community data, it is the type 2 diabetes data, and we have very well shown nearly 3/4 of the individual with type 2 diabetes is having statosis, and 28.6% has fibrosis. And the amount of the scores which we have discussed, like APRI, FIB-4, NFS, all these scores are having a association of the varied sensitivity and specificity with this. Now this is our own center. Here we have not taken the data from any other center. This is the DMDSC experience or our own center data. Sorry. So what we have done, between November 23 to November 24, we have taken around 1,267 patients. Those who were taking alcohol or were having other forms of diabetes, those were excluded. So ultimately 800 plus patients we got, and for them we have done all the anthropometric measurements, waist circumference, blood samples were taken, lipids, and all the parameters were done. And all the ratios like AST to platelet, we call it as APRI, FIB-4, and NFLD fibrosis score were calculated, and it was done by the model Mini Plus FS 430, which is there in our center. And we have classified, I told you, less than 6 and less than 8.2 and less than 9.7. These were the grouping was done with the fibrosis, and CAP was also classified as a normal when it was below 238, and then 238 to 260, 260 to 290, and 290 to 400. Like this we classified the statosis. And this is the flow chart, just how the study was taken, how the patients were taken. So from 1267 we got the 853 patients who were taken for the study. When we looked at the CAP score or the statosis with the severity, what was clinical parameters which were related? So what we found that BMI and waist circumference, both were getting very well correlated with the this CAP scores. We can very well see as the waist circumference is increasing from 93 in the S0 category to the 102 centimeters in the S3 category, there is a significant increase in the CAP scores, same as happened with the BMI. And at the same time, SGPT also shown a very good association. When we look at the fibrosis scoring, then we found that BMI has lost its significance when we looked at the this fibrosis, but waist circumference is still having significance. So simple measurement of the waist circumference can points towards the fact thus this person will be prone to having fibrosis or steatosis. It doesn't cost any money, and we know the criteria: less than 80 in females and less than 90 for the males is the waist circumference we have to mention and measure. Simply we can do it. And at the same time, when we looked at the fibrosis, all the platelets and AST, ALT and all the scores were correlating very well. So when we did the multinomial regression analysis, and we have traveled a lot, Zeba sitting here, she has done a lot of data for our group, and when we have compared the S0 as a reference, what we have seen that waist circumference is still holding the key, and APRI scores also shown the hold the key. But if you look at the FIB-4 score, it is started coming down. It was significant in the other way. As the fat is increasing in the study, our patient group, then the fibrosis is coming down in the FIB-4 score. That has been probably, it could be because of fat and all, but definitely it's not correlating well. So when we looked at the fibrosis, what we have found, the higher waist circumference, FIB-4 score and APRI has shown very strong association. Here also waist circumference holds the key, and FIB-4 and APRI kept on increasing when the fibrosis levels were increasing. So if you are not having a fibroscan, if you are not having a advanced studies or advanced methodologies to check it, then you can simply just calculate the FIB-4 score or APIR score and measure the waist circumference, and you can find out, depending on the scores, if it is more than 1.3 or if it is having higher values more than 2.6, we can definitely find out that these patients will be at the risk of getting the MASLD. So when we looked into the steatosis and fibrosis, as for the BMI categories, we can very well see that the trend was very good for the steatosis as far as BMI was concerned, and it was significant. When you look at the fibrosis grades by the BMI, though on the higher BMI group we are seeing a higher values, but it was not very significant, but it was showing a positive trend. When the steatosis grades were stratified by the waist circumference in men and women, both were significantly showing the association. So the waist circumference has clearly is a winner in this particular data set and is showing that there is a good correlation. When we saw the fibrosis with the waist circumference, men and women, here also we can see the trend is very much positive, but men has shown a very significant association. Women, we can see very good trend with the waist circumference, but the p-values were not very significant. So when we looked into the sensitivity and the specificity of these scores, and then we found that the FIB-4 has shown the best specificity and sensitivity. So it is neither ruling out the normals, neither ruling out the guys who are having MSLD much, neither it was doing all the true positives it is diagnosing. So this is a more balanced score in our data set. If you look at the NFS, sensitivity is very high, but at the same time it is true negatives also are missing. And if you look at the APRI, here this specificity is 79.8%. So in this data set we see FIB-4 is very simple to calculate also, and it is very well 1.3 to 2.6 is the mostly range. So what could be the take-home message? Our data suggests that a substantial proportion of the study population has steatosis and nearly a third had fibrosis. Waist circumference, a very simple tool, we can measure the waist circumference with a simple non-stretchable tape, and we can show it that it has emerged as one of the key determinant for both steatosis as well as fibrosis. And what could be the reason why the waist circumference, not the BMI, showing the stronger association could be because of that. It is the measurement of the central obesity. So we know that obesity itself is a risk for the inflammation. So it is creating a low grade inflammation. It is increasing the reactive oxygen species. It is increasing the inflammasomes in the body, and it can lead to the increased insulin resistance. We know that central obesity is associated with the increased insulin resistance. And we also know that the hyperinsulinemia and insulin resistance itself is an independent factor for the complications. And that's why it could influence the LSM also. So what is the importance of all these lectures and the data sets is that early detection is the key. If we can diagnose it early, we can find out the cutoffs early, we can very well prevent it from going towards the cirrhotic changes or the SCC or the carcinomas, and we can very well reduce the morbidity and mortality in this set of patients. And population studies are needed to make the findings generalizable. We should do a study which should be well funded, where we can look at the normal population, and we can look into the normal population, not only type 2 diabetic subjects, to look at this particular MSLD and its consequences, thinking it as a generalized systemic disorder. Thank you very much for the kind attention, and I am very thankful to Zeba, who is our AGM and head, and she has done a lot of data, and Dr. Varun Anil Damle, he is our postdoctoral fellow. He has done a lot of work on these papers with us. Thank you very much. Thank you.